Hi, this is Dr. Tim Conley at Yeshiva University, and we're going to talk a little bit about opioids as a substance to which an individual can develop a use disorder, substance use disorder, opiates. Opium itself, it's a naturally occurring mixture derived directly from the juice of the opium poppy plant. It's been grown and harvested for eons, and its use is recorded in ancient literature in a couple different areas of the world. There are medications which can then be made from these substances, and one of those was heroin, invented in the last century. We would want to say that several exogenous opioids are significant for opioid use disorder. That is, opioids which are introduced into the body. Just a note, you could refer to as an endogenous opioid as one which was naturally occurring in the body. Well, why would opioids, derived from a poppy plant, occur naturally in the body? There is a neurotransmitter system in the brain called the endorphins, and endorphins are a naturally occurring brain chemical which is largely responsible for relieving pain and with a side effect of feeling better. You can stimulate endorphin production in the brain with pain or with endurance. And there are many people who engage in athletics because they are endorphin junkies, or they are trying to get that natural high that can come from sustained exertion, weightlifting, marathon running. When you push yourself to endurance, your brain tries to take away some of the pain by producing this endogenous opioid-like substance, chemically very similar to the exogenous opioids, which include heroin, morphine, oxycodone, codeine, meperidine, pentazoazine, hydromorphone, hydrocodone. They're all listed in your readings. There's quite a long list, all of which have a same base chemical structure to them. It's just it's morphine with a twist. Some can be manufactured directly from the derivatives of the poppy. Some are manufactured entirely in a pharmaceutical laboratory. Morphine is a natural product of the poppy plant, and as I said, the use dates to the early 19th century. It was isolated, I think, in 1817. It's been a long time been around. Codeine has long been used for controlling coughs because one of the effects of opioid drugs is cough suppression. So there are synthetic agents, those which are derived from the morphine, and the first is heroin. It was derived by the Bayer Manufacturing Company, same Bayer that makes aspirin, and it is a very, very potent form of opioid and highly addictive. Please note that heroin, while people usually think of heroin as being a drug that you inject, it can be snorted, it can be used intranasally, it can be smoked. High purity heroin can easily be smoked or snorted, and as a route of administration, that will get it into your body. I would stress that in this module of the course that you read through, the specific effects of the different opiates, hydromorphone, very potent analgesic, very much takes away pain. Hydrocodone, prescription medication for relatively minor pain. It is important to note the context in which I'm presenting this little lecture is that the United States of America is caught in what's called an epidemic of opioid use disorders. There are more people addicted to opiates now than perhaps at any other time in history, at least known cases than at any other time in history. So to try to give numbers, later in your chapter, it presents some data from 2014. That is light years ago. As we turn the corner to 2021, you would want to look at the Center for Disease Control and the Substance Abuse Mental Health Service Administration websites to look at the most frequent estimates of people using. Let's look at, non-medical use. So all of this class of substances, they were painkillers. They were designed to deal with pain, and as a prescription medication used in a medically supervised manner, they are very effective at using pain. None of them really should be used long term uh, because of tolerance, dependence, and withdrawal. But as a short term medication to control acute pain, they're very effective. As a long term strategy to manage chronic pain, they are effective at managing the pain, but the side effect of dependence emerges, and this is what has happened to the United States recently. Medication, which really should have only been used for short-term acute pain, was prescribed regularly. It was marketed. It was pushed. It was, advanced by the pharmaceutical companies, which are now being held criminally liable for doing so. It was advanced as a means of dealing with chronic pain. Well, a lot of Americans deal with chronic pain, from arthritis to degenerative disc disease to, a variety of different things resulting in chronic pain, especially among older people. Physicians were like, oh, there's a safe opioid, we'll use this. Well, it's not safe. Pharmaceutical companies knew it, and they're being held liable for it. Non-prescription use, recreational or illicit use of opioids, people will use them because there's what's called a euphorogenic effect. There's a word for you. It has the effect of giving you a euphoric bump. Just as your brain can produce this endogenous substance called endorphins, which will relieve your pain, it also gives you a feeling of well-being. Again, back to the endurance athletes. They want that runner's high. They want that kick, that natural response that your brain can give you to being put under duress. But you can get that from a substance as well without having to do any of the weightlifting or marathon running. Some people are going to take these prescription medications because, well, they're not illegal. I'm not doing something illegal. It's not like I'm shooting heroin, to use a term which has become stigmatized. I'm not shooting heroin. I'm just taking a medication. Well, your brain doesn't know the difference, whether it's legal, illegal, illicit, licit. Your brain will become dependent on that substance just as well. Think of it. You flood your brain with a chemical which produces euphoria and takes away the pain. When you do that, your brain stops producing endorphins. Why would it? If you're going to occupy the receptor site with an exogenous opioid, if you're going to tie up that receptor site, this receptor site, which is producing endorphins, stops producing them. That's okay as long as this stays lit up. When that goes away, if it's transient use, this will start to produce endorphins again. But with a person who is chronically saturating the neuroreceptor sites for endorphins with an exogenous opioid-like substance, heroin, morphine, etc., you saturate those receptor sites, the nerves which are producing endorphins will stop producing them. Eventually, they will never produce them. Then you take away the exogenous opioid, the heroin or the morphine or hydrocodone or whatever. You take that away, you're going to have a person who's in pain because they have no base level of pain control. You're going to have a depressed mood, but you're going to have somebody who's in withdrawal, and that withdrawal won't go away. The book chapter, which includes historical features, that's a good idea. Go ahead and read through that. I've already commented on the epidemiology. You really have to consult websites to get the latest numbers on how many people are using. I think the text does a pretty good job of showing, just as of 2014, there were 914,000 people who used heroin in the last year. That's almost 1 million people. So yeah, there's a lot of folks out there with substance use disorder, heroin or opioid or OxyContins, oxycodones, hydrocodones, hydromorphones, the list. There are many, many people out there who are addicted to this at this point, and it can result in death. We've talked about tolerance with other substances. It's defined as the loss of an effect after repeated use, leading to the need for higher doses to get the desired effect. All opioid medications lead to tolerance and physical dependence. That is, you will withdraw, you'll get sick when you stop taking them. I worked with an addiction medicine psychiatrist years ago, Dr. Kishore, and he said he wished that there were a warning attached to every prescription that a physician would write that said, I'm going to prescribe you this OxyContin, and I'm going to addict you. You will be addicted. You will have withdrawal when you stop using it. You'll be uncomfortable. If you take the substance to relieve that discomfort, you are going to go on a ride because it will take more to get the same effect. Eventually, you'll take a fatal dose. Acute opioid overdose is characterized by mental state altered into stupor and coma, respiratory depression, difficulty breathing, difficulty removing carbon dioxide from the body, and pinpoint pupils. A full opioid overdose can be effectively treated with an antagonist. Now, an agonist and an antagonist. Agonist is a substance which will occupy receptor sites in the brain. An antagonist will prevent them from doing so. So if you give somebody who has overdosed on an agonist, a heroin-like substance, if you give them an antagonist, it will reverse the effect. If they're on an antagonist, it will prevent the effect. Naloxone will do that. So that kind of is the quick lecture on opioids. There's, you want to read your chapter thoroughly and take a look at that. It's a very contemporary topic. It is something which is causing an epidemic of deaths, of overdose-related deaths, and deaths of despair, deaths of desperation in the country right now. It's not going to go away quick. There are many, many people who will need to be on medication-assisted treatment. Whole separate module of teaching on medication-assisted treatment a little further down the course sequence. There are many people who will need to be on medication-assisted treatment, which is they will need a replacement substance to occupy those receptor sites for indefinitely. Ever take them off of it, and they will be at risk for relapse, overdose, and death. Very difficult substance to learn to live with the after effects of. So this is the lecture on opioids, and look forward to more substances to study shortly.